Welcome everyone to today's program, which is brought to you by SpineMark. I am Robert Kurtz, moderator for the webinar. The program will begin with a presentation by Marcy Rogers of SpineMark, and then we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Marcy will attempt to answer as many of your questions as she can during the Q&A portion of the program. It is now my pleasure to introduce our presenter. Marcy Rogers is President and CEO of SpineMark Corporation, the premier global spine service company for the development of spine centers of excellence and spine research organizations. SpineMark works with physicians, hospitals, facility companies, third-party payers, and medical manufacturers in the fields of spine, pain, orthopedic surgery, and neurosurgery. For more than 30 years, Marcy has worked with leading healthcare professionals, facilities, and medical device manufacturers to advance her goals of improving patient outcomes and satisfaction. I'll now turn the floor over to Marcy for today's presentation. Marcy?
Thank you very much, Robert, and welcome everyone. Greetings from a very chilly Southern California, and appreciate the opportunity to spend some time talking with everyone today. We are, as I mentioned in the article I recently published for Becker's Hospital Review, this is a time of change, and certainly we're seeing large changes in terms of healthcare delivery and healthcare reform. And if you look around at the headlines that are coming across front pages of papers today, you have Dr. Cosgrove at the Cleveland Clinic talking about the opportunities as well as the obstacles to avoid in healthcare reform, and things that the Cleveland Clinic has done to mitigate some of the potential downside, the declines in revenue and the formation of accountable care organizations and others. Then on the other hand, you have just recently on the 12th of January in the New York Times, the movement, which has been coming for quite some time, to actually tie doctors' incomes to quality of care metrics. We've heard Medicare talking about these types of report cards for physicians. We know that Medicare last year awarded 1,577 bonuses to hospitals who met quality metrics. And we also know that there were other hospitals that did not get bonuses because they didn't meet them. And all of these penalties, the penalties as well as the bonuses, are being very clearly delineated as reported in the Kaiser Healthcare News. Last but not least, and of course there's many other headlines hitting, you're starting to see hospitals forming their own systems so that they can form their own insurance company. And that's a relatively new trend and one that I think we're going to see more of. So this is a time of transition and change, and it's also a time of opportunity. Next slide, please, Rob. One of the biggest opportunities that we've seen coming since the early 2000s, if not before, was the growth of medical tourism. A number of years ago, back in the early 2000s, you were looking at an industry that was probably less than a $2 million or more revenue center or destination. But with the advent of patients opting out of a healthcare system in their country to seek other places where they may have a shorter waiting time, or that they could have the opportunity to take advantage of technology or new materials or new implants that aren't approved yet in their home country, or if it's just too expensive. And the growth of this industry has just exceeded all of the expectations. Hospitals around the world are actually setting up destination centers for niche programs like spine, like cardiac, like orthopedics. And in 2010 alone, the revenues off of global medical tourism were $40 billion. We're even seeing here in the United States many groups forming what we call surgical benefits companies, where they're managing for employers the benefits for their members, and actually looking at negotiating with institutions like Geisler in Pennsylvania and others for surgical specialty care for case rates, including a guarantee during the 90-day post-op global period. So very, very big changes and transitions in how we're becoming consumers of healthcare as well as utilizing it. Next slide. What we're going to talk about today this is just an agenda. We'll run through a number of these topics, the rationale for developing a spine center, how some of the benchmarks and measuring success, developing the business model, some of the administrative milestones, opportunities for marketing a center, and then doing questions and answer. Next slide, please. So let's start with the rationale. This next slide shows some of the components, the clinical as well as the interrelationship of those components in a spine center. Basically, one of the most important features when you're setting up your center is you really want to be able to create a full continuum of care that starts with conservative care and includes all of the diagnostics necessary. From that, you'll look at having physical medicine and rehab, interventional pain and neurology as a key element of the center, usually under the conservative care portion. One of these specialists may end up being your gatekeeper. Every center needs a gatekeeper that's almost like the traffic director, if you will, a medical director to kind of look at triage and workups on patients where therapeutic needs are not obvious. The whole pain component, both acute, interventional, and chronic, is key. We know that globally there are millions and millions of these patients who are looking for help and care, and until they can receive it, they will keep shopping, and that's a very big part of the spine center. On the spine side, there's a full array of various components of spine, whether it be complex or the more extensive deformity. Degenerative, minimally invasive spine is really becoming more and more prevalent these days, and that resonates well with Medicare's shift to trying to move more and more of this to an outpatient setting, and then trauma in general. In some centers, spine centers, musculoskeletal is included, and so I put that here, but it also can be a standalone center in a hospital. And then last but not least, tumors. Next slide, please. So when you're looking at the whole array of trying to put all of this together, the key is to create an integration and a consensus and, most importantly, alignment of all of the stakeholders. And so here I'm talking about hospitals, the providers, the physicians, and the patients, and any management entity that's involved in the project. Next slide, please. When you want to look at the stages of development for putting together a spine center of excellence, there's really 3 distinct phases. And it always starts with planning and feasibility. These usually take us anywhere from 90 to 180 days, depending on the complexity of the project. But that's when you're going to do a very thorough assessment of your market, identifying opportunities, threats, risks, and those sorts of things. You'll create a budget plan with forecasts, and actually also to try and gather data on from the various team members in the hospital, both clinical and administrative, as to their vision for the center. Once that's completed and it's a positive movement for the hospital and the providers and the physicians, then you go into the implementation phase. And in that phase, you're going to be looking at trying to create some governance methods with the providers as well as nursing and administration in the hospital So you'll form a clinical operations committee of usually 5 to 7 members from the multidisciplinary team that will oversee the clinical aspects of the center. And usually that's the core specialists: neurosurgery, orthopedic surgery, interventional pain, physiatry, and anyone else that might fit from the culture of that team to be a member of that group. That's a physician-driven, provider-driven entity. You're going to look at trying to put your triage process in place for managing patient throughput through the centers, the use of your clinical algorithms, training of your nurse navigator, if you will, the recruitment of any outside staff, looking at the implementation of research, as well as the creation of a marketing plan during this final stage of implementation. From there, and that usually takes 6 to 8 months, again, complexity oriented. From there, you go to go live management, and that's when you're really going to start to be implementing all of the quality metrics that everyone in the industry, the insurance companies, the regulatory agencies, employers, and patients are now looking to find out if, in fact, your center has a quality measurement program, how it's being implemented, what components are there, and all those sorts of benchmarks and standards. You'll implement your marketing plan and your operating plans. You'll also have, through your clinical operating committee, a utilization review and a quality assurance program so that the members of the team can, particularly the clinical operating committee, can work with the group using outcome data and utilization data to guide decisions, look at any outlier instances of care as an internal continuous improvement process, and set objectives for growth. Next slide, please. So why a spine center, and what are some of the strengths? Well, as many of you know, spine is a feeder, if you will, to almost every department of a hospital. And there are a variety of secondary or primary conditions that can contribute to spine. And what you end up with this type of center is a broad catchment of referrals from multiple fields that can only help you diversify your payer mix, increase your referrals, and also meet the new demands of many of these insurance companies starting to set their own criteria for working with and accrediting a center of excellence in spine. You'll also be able to start with the primary and ancillary care aspects of the patient's spinal condition, and really reconnect and develop a meaningful dialogue with the existing treating physicians as well as the primary care. A lot of times what we've seen in many of these situations is we'll enter into a situation where the referrals from primary care are being downgraded because the patient gets sent by the primary care physician to the center, and somehow or another gets lost there for a few years and never comes back to he or she. This whole model is about integrating all of those components and creating a communication and coordination that is patient-centric and geared towards the complete rehabilitation and communication amongst providers of the care of this patient. So the model is operative and non-operative. There's an opportunity to capture downstream and spin-off revenues from ancillary activities. You've got your metrics for outcomes, and it allows you also to bring in a very important component of this center, and that is participation in clinical research to drive advances in spine care. This is very, very important as a clearly defining element of your center. Next slide, please. So the opportunities, wherever you are, and I know today we have, we're fortunate to have people from around the United States as well as outside the country, but wherever you are, the opportunity is that in today's climate, and because of what's really happening in the field of spine, the move to more minimally invasive technologies, the trend towards more focus on outpatient sites of service, that and the growth of cash pay or medical tourism patients or employer-directed contracting with groups for their employees. So you, more than ever in this particular time, have the ability to brand and create an international, national, regional catchment area type of branding as a destination for spine. The other important opportunity is to expand and augment your primary care referrals by sponsoring educational programs on when to refer a spine patient, where to refer them, and how the process works between primary care and the Spine Center of Excellence. A management system that includes all of the quality focus metrics is not only proactive, it's going to be absolutely of paramount importance in the success of your spine center, not only from an operational point of view, but from a reimbursement and market leveraging point of view. You've got an organized system for patient throughput that is decided on amongst the clinical operating committee, so it becomes a measurable event. And everything included in that system, conservative care, operative, non-operative, are addressed in the delivery system. As I mentioned earlier, clinical research is going to drive a new class of patient referrals to your system, many of which are going to be cash pay. As in our experience now, many of the device manufacturers, when they're either doing outcome studies or clinical trials, they're looking to accelerate enrollment by paying for clinical services on a cash basis so that they can get through the requirements of the commercialization of their product or to present data for coverage. There was a very, very interesting article, as I mentioned earlier, when we started, that was from the interview with Dr. Cosgrove and the Cleveland Clinic. And what they're doing is, you know, and we're all not Cleveland Clinics, I understand that, but what he focused on was the absolute need and the future for niche specialties and the ability to think outside the box, that the way we've approached marketing and building catchment area referrals and all of that needs to be changed to reflect social media and, when possible, international types of collaborations, setting up satellite screening clinics and using those as a feeder to centers. So these are all the opportunities facing spine today. Next slide, please. So let's talk about success. Next slide, please. And I'm going to mention here some of the benchmarks, protocols, and metrics. Next slide, please. When we're talking about accountability and collaboration, there's a contribution that was required from the physicians and their leadership. I'll draw particular attention to participation standards of the members of the team, and these are based on training and credentialing. On the hospital side, what the hospital will contribute in terms of sponsoring the location, the director, the nurse navigator, and that. And together, you're collaborating to manage quality and cost of care. Next slide, please. These are, on this slide, operational, financial, clinical, collaborative, and market performance types of benchmarks for measuring success. And under each one, there could be hundreds of items that you can measure. But, you know, on the operational side, you're looking at length of stay, continuum of care, utilization, financial, obviously, contribution to margin, return on investment. Very, very important clinical, patient satisfaction, return to work, complications. So all of these come together as the backbone of your quality management system, your protocol, if you will. Next slide, please. Very important to talk about transparency and preventing errors. All of this is now very much out in the open. Metrics. I would call your attention under transparency to make even things like spine center policy procedures available, as well as continuous quality improvement plans. We know we're starting to see more and more use of report cards under performance, credentialing, and always focusing on patient satisfaction as a key indicator of efficacy and outcomes. And then last but not least, the fact that we're in an environment where the internet and social media are driving so much information, patients are using those vehicles to identify their providers. And payers are starting to look at bundling services and paying for quality and data based on outcomes. And if anybody has been trending all of this, we're also now seeing accountable care organizations not just being a Medicare initiative, but moving into all the payer types. Next slide, please. So specialization breeds better outcomes, standardization. Next slide, please. This talks about the protocol management system that is necessary to handle all of the operational planning, monitoring, and measurement for your center. Next slide, please. We're going to now talk about the business model. Next slide, please. So the business model is an integrated delivery system that coordinates all of the components of care. Next slide, please. And this slide talks about some of the qualifications to be a center. We like a catchment area of about 500,000, at least somewhere between 250 and 500,000, a strong base, primary care, industry heavy if possible, access to an international airport, at least 3 to 6 surgeons maybe under a service line, strong diagnostics, good protocols for the ER, and a facility and a group of providers who want to create a virtual or physical infrastructure. Next slide, please. The various types of treatment, depending on the providers involved, are on this slide in terms of deformity, tumors, minimally invasive, complex spine, general spine, diagnostic and therapeutic injections, ablative interventional pain, pumps and stimulators. This is the full array. Each center and their physicians and providers can look at their individual. Next slide, please. This is the structure we're going to talk about next. Next slide, please. Very important, central point of access with a full array of services under 1-800 number. Your triage system based on clinically based, medically based algorithms as created and approved by the Clinical Operations Committee. Nurse navigation as a concierge or medical case manager, if you will, very important component. Clear marketing, we talked about the need for research. Evidence-based care through outcomes, documented and accountable by outcomes, and transparency. Next slide, please. We know, and I'm sure many of you know, that surgery is only one component of comprehensive care. Traditionally, what we see in these centers is non-surgical is 90% of the volumes, and that includes everything from diagnostics, injections, conservative care, all the way down the care continuum. Next slide, please. This is the full-blown scale of the multidisciplinary team with the primary and secondary disciplines involved in the Spine Center of Excellence. Next slide, please. Structural elements, it's physician-driven through the Clinical Operating Committee. The team provides the full approach. There are monthly team conference staffings of patients. There are pathways and algorithms. You have a defined continuous quality improvement program, and you're always advancing care through outcomes. Next slide, please. Triage, we've talked about. It's very important that the patient is assessed to go to the right physician, have the right treatment, the right type of provider that fits with their workup and their treatment plan. And there's various tools that can be used. We use a system in our centers that allows us to manage this quite well. It's got all the trends and guidelines and algorithms that can be built into it. It's called Priority Consult, and that's been very successful in helping us launch and build our centers. And then on the inpatient side, very important to have close communication with your ER staff, and they have to be trained many times on when to refer patients. Next slide, please. Navigation cannot say enough good things about the impact of the nurse navigator on the success of the spine center, coordinating inpatient and outpatient care pathways, and serving, very important, as a support system to the patient and their families who come in many times from outside the area or from the area, from outside the country, if you will, to be there for surgery or some types of procedures. Next slide, please. So the link with the clinical operating committee and the team is typified in this slide, and the components of the case management, the coordination of care, the communication among multiple specialties to provide better outcomes and better quality care. Next slide, please. Governance structure for the clinical operating committee, they usually set the inclusion criteria for each member or specialty of the team. They'll implement any niche programs, like for instance, many centers have arthroplasty, defined niches under them, tumors, chronic pain, interventional pain, if you will, those types of things. And they meet monthly. There's usually a 2-year term for them, and we usually rotate, have the group rotate other members in after the initial 2-year term so that everyone has a chance to kind of participate in the center and the governance. Next slide, please. So what's the cost of not doing this? Well, if you're in a market where there's a lot of competition, there's an out-migration, dilution of market share, many times you'll end up not being compliant with payer guidelines for quality and metrics and process benchmarks, and that will impact your market share. Next slide, please. So we're now going to talk just briefly about some administration and logistics. Next slide, please. This is capturing just the phases that I mentioned earlier, phase 1 and 2 for the planning of a center and then the implementation of a spine center. Next slide, please. This is a sample timeline for phase 1, 2, 3, and go live with all the various components that we look at over a 6 to 8 to 12-month period. Next slide, please. And next slide, please. This is an implementation checklist that we use on an ongoing basis during the go live and going forward for the center. And notice we were talking about administration, marketing, quality improvement, and medical staff. Next slide, please. Last, I'll just touch on marketing. Next slide, please. The opportunities I mentioned earlier is creating this destination center. And how do you do that? Well, right now, one of the most important things, and as I've mentioned throughout this program, is having a measurable, focused operating management protocol as a quality metric tool. And then secondarily, understanding what the consumers and the patients in your market want from a spine destination center, and then branding with that information. Next slide, please. So marketing and education is broad-based. We cast a wide net, community hospitals, wellness programs, screening programs. We use medical education tremendously, heavy on medical education, patient education, payer education, and some advertising. We use the data, and we make our data transparent to third-party payers and employers on outcomes, and also involve the physicians and the allied team in patient-type seminars, medical-type conferences to educate physicians from around the area or the region or the three-state area. Next slide, please. Social media and the internet are really driving a lot of this right now, so it's very important to be able to have all of these components not only in your marketing plan, but use them to document your accountability. Next slide, please. And the transparency, as I mentioned earlier, is very, very important to payers, employers, managed care, physician groups, documenting your outcomes, talking about return to work, and having the ability to have direct access, publishing your fees. All of that is all part of this new trend towards complete transparency and accountability. Next slide, please. This is just a template for a marketing program focusing on awareness, comprehension, conviction, and preservation as you look out and plan over the course of the implementation of your center where you want to build on, shore up, create awareness and conviction. Next slide, please. And capturing the clinical trials, as I mentioned earlier, is a very unique way to build a strong presence in your marketplace as what we call a market mover, and position the opportunity to bring in patients who want access to new treatments that they might not normally have access to. And again, these 50% of the time the sponsor may elect to pay cash for clinical services, so that's another important component. Next slide, please. So now that's the core of my content for this presentation. Rob, I'll turn it over to you.
Thank you, Marcy. Thank you for a detailed and incredibly informative presentation. As you noted, we're now going to begin the Q&A portion of the program. As a reminder for our attendees, you can submit any questions you have for Marcy by typing them into your control panel, the space labeled Enter a Question for Staff, and clicking Send. I want to thank those of you who submitted questions prior to the program. We'll try and get through as many questions as we can. And if you submitted a question in advance or now and Marcy doesn't get to it, I'm going to make sure to pass along all your questions to her. I certainly encourage you to follow up with her directly. Contact information is on this final slide here, and you can also reply to any of the emails you've received about the program. Let's begin. First question. I understand Blue Cross and Blue Shield has developed an accreditation process and criteria for being designated a Blue Distinction Center in their network. Where do they get their guidelines? What are their criteria? And is a trend that you think other payers will follow?
Well, that's a great question, and we've just recently encountered this in Texas in particular, in that Blue Cross arbitrarily and Blue Shield took it upon themselves to create committees of specialists in orthopedics and spine to be able to come up with their own criteria for being able to contract with a center, all based on quality metric guidelines. It is a very intensive application, and in order to pass, you have to meet at least a minimum of 60 points on their criteria. And they ask for everything from operating procedures, org chart, manuals for quality assurance, plans for utilization review. They come on site, they'll evaluate your program and tour the facilities. And this is a trend that you're going to see not only from Blue Cross and Blue Shield, but from many of the payers who look towards clearly defining the niche and the requirements of spine and orthopedics for treating large volumes of patients in a quality-driven, cost-effective way. So what I was particularly pleased when I matched up our spine protocol management system with Blue Cross, we found that, that we exceeded by at least 80 points many of their quality criteria. So if you're creating a center and you start with that type of protocol as your foundation, you're going to be in a great position to not only meet the metrics of these new payer initiatives to accredit centers of excellence based on their own guidelines, but exceed them.
Thank you. This next participant understands the value of giving outcomes to payers, but says he's convinced that it doesn't matter to them. Payers make authorization very difficult at times, and so it'd be great if payers would provide him with a list of outcomes they're looking for, rather than guessing on what outcomes that they want. Any suggestions for what to do in this situation?
Well, you couldn't be more right, because we get a lot of mixed messages from third-party payers. On the one hand, they're always asking us, now they're saying we want your outcomes, and then it turns out that because your outcomes don't necessarily match their criteria, you could be penalized for it. So very, very good question. We know, and it's very important for everyone listening to this, that right now, if you are collecting your outcomes, there's several opportunities. Number one, to become designated as one of their distinction centers. Number two, to leverage your reimbursement, because we know that with data, we have found hospitals within a 5-mile radius of one another getting completely different rates of reimbursement just based on quality criteria. There are 5 major categories that the insurance companies start with, and it's usually based on return to work, return to function, patient satisfaction, very big, quality of life. And those kinds of criteria really, really drive a lot of this. So my suggestion would be to proactively develop a payer education program that on a quarterly basis you're meeting with key payers in your region, providing white papers on your outcomes, talk about what their internal metrics are, and as much data as you can, even break it down into very specific areas of cost of care, error prevention, medical records. All of those sorts of things that all fit together in this will help you, because they don't necessarily want to tell you what their criteria are. But if you take a broad-based perspective and go in and try and develop relationships, I think you can come to some understanding of how you can use your outcomes and have it benefit you, not only in the reimbursement side, but even on the pre-authorization side. Many times they don't know about new technologies, new implants, new approaches to care until they get a claim across their desk. And then that's why we believe it's very important to also educate the adjusters, if it's a work-related injury carrier, or the case managers by doing, CEU accredited programs for their on-site team.
Thank you. Let's see if we can get to a few more questions, and then I'll give Marcy an opportunity to share some final thoughts. Marcy, what criteria is being used, and what types of data is Medicare using to pay quality performance bonuses to hospitals? And do you see this program growing, and do you expect other payers will follow suit?
Right now, Medicare is got a very, very long list of quality metric data they're tracking. Length of stay, the patient experience, the entire patient experience within the hospital. How long did it take them to get their lab tests? How long was their procedure? Were they admitted to step-down unit? I mean, the list is very, very extensive. And what they're looking for is a way to identify those facilities that meet the highest standards of quality metrics in an institutional setting. I see many payers that will follow the same pay for performance. As I mentioned when we started, New York, in the state of New York, they're going to start tying the payment to physicians. based on their performance and their discharge of patients in a timely manner, the completion. This is all a trend that is only going to keep getting bigger and bigger and bigger. So it's very, very important that if you're planning to develop one of these centers, that you really carefully examine and start with your quality metrics and build from there as you're planning and developing your program. If you're in an existing center, there's never a better time to really revisit this and evaluate where you can shore up some of your accountability measures and benchmarks and put this into some kind of standardized protocol fashion. We used ISO as our standardization protocol so that we could have a measurable event for each and every function of the patient's experience in the hospital, the operations of the center, the return on investment, the financial side, and that whole process.
Thank you, Marcy. We'll get to a couple more questions, and then we'll wrap up. This is a multi-part question from a participant, so just let me know if you want me to repeat any of the questions. So this participant says that our market is oversaturated with vendors trying to sell implants and products that will continually cost us profitability in our cases. In many cases, we can't even break even on the case. How will the creation of a spine center help us? That's question one. How do we address these issues with our vendors? Two. Finally, what can we do to align with our physicians?
Okay, so this is a problem that I probably hear everywhere I've been over the last 10, 15, 20 years. And it's not just a United States problem. It's the United States, but it's also becoming a global. The issue with implants and your supplies and your materials is really one that has a kind of a three-part approach. The first and most important part is that you have to involve the physicians in some type of structure with the hospital in negotiating with vendors and identifying costs. There has to be consensus. And the second part is that what the vendor is going to always say is, you know, I'm not going to give you a discount. So you also have to work out a strategic partnership where they're not just vendors. You know, you all are aligned in this whole process. So having the physicians involved in the negotiation with vendors, creating a standardized kind of preference list for your cases and the cost of those cases and what the anticipated reimbursement is so that you're not taken by surprise, are very important components of dealing with this issue. Right now, with what's coming with healthcare reform, I think there's a much greater willingness to proactively come up with solutions in a focused kind of interaction with your vendors, perhaps identifying a preference list among those who will be willing to give you more favorable rates in return for consistent business, and leveraging your physician relationships for the benefit of the patient, the hospital, and the reimbursement system, which with comparative effectiveness research is going to come into focus because many of the insurance companies are going to have designated items on their medical surgical list, their implants, their biomaterials that they believe to be more effective than others, which will drive, you know, reimbursement and resolution of this problem.
Thank you, Marcy. Before we get to our final question for the Q&A, just want to let all of our attendees know we'll be hosting another program next month, February 13th, on clinical research organization management. You'll be receiving an invitation to join us for that program, and I certainly hope that you will. Final question before I ask Marcy for some final comments. And again, for those of you who submitted a question we didn't get to, don't worry, I'll make sure that they're passed along to Marcy. Final question. We've been trying to develop a spine center with local and community surgeons for about 10 years, and to date we can't even get them in the same room with one another. How do we overcome territorial differences and ego, and hopefully replace that with consensus and communication?
It's a lot. I've seen that so many times. This is not an unusual problem, but what usually happens, and the biggest way to create some consensus and move this forward, is that it's very important to have a facilitator in this process who has no vested interest, if you will, in the outcome of the actual center. And so that what we find is many hospitals will bring in a third party, an independent party, whether it's a physician to kind of mentor everyone, whether it's a consultant to kind of create the process and drive it, or whether it's a national or international expert in the field to come in and kind of drive what the opportunity could be and kind of put everybody together in a kind of working model. I've seen retreats used for those sorts of things. I've seen, planning sessions. But the idea is if you can get everyone in a room and get away from the individual territorial or competitive issues and look at the broader base of the program, over a period of time, that together with the creation of the Clinical Operating Committee will be so successful in realizing the fruition of your center and a long-term plan for its success.
Excellent. Thank you. That concludes the Q&A portion of the program. Marcy, I wanted to give you an opportunity to share just some final thoughts before we wrap up.
Well, from a perspective of where I sit today, this is a tremendous time of opportunity for spine. There is a great deal of negative perceptions out there amongst payers and certain groups that we overutilize. But at the end of the day, this is really for and about and driven by patients. And I think that if we can take all of the change, the transitions, some portion of negativity, beneath all of that, there's a great opportunity. And I would encourage everyone to be thinking about what we can take away from what's going on right now and putting it into an action plan for our center.
Excellent. Thank you, Marcy. Again, thank you for the presentation, taking the time to address a number of questions. Certainly want to thank all the participants for setting aside some time to join us. Strongly encourage you to contact Marcy directly. Again, contact information is on this final slide. You can certainly reply to any of the emails you received about today's program. Love your questions, your feedback, requests for topics for future webinars. Anything we can do to help you, please don't hesitate to contact Marcy. Again, just reply to any of those emails you received about this program. And noted earlier, I certainly hope you'll join us next month for our program on clinical research organization management. With that, this concludes today's program. I wish everyone a wonderful day, and thank you for joining us.
Thank you, Rob.